Um,
GS, thank you very much for introducing Dr. Ramesh. And unfortunately, we can't have you here in person, but this is the plaque we have got for you, and we will see that it reaches you. Thank you very much, and please start your oration, Dr. Ramesh.
Thank you, Govind. Thank you. And I must thank, and I'm really grateful that all of you put together has given me the opportunity for this oration. And I must say, Govind is the president of our society, and the executive committee and the organizing committee have given this opportunity. I'm a clinician, as you all know. Next slide, please. I'm a clinician. I've always been a clinician. I'm still a clinician. I may still talk about a lot of data and research, this and that, but at heart, and I still believe that clinicians are the ones that really have to do things. And we have always done that. And the Hippocrates, as he said, it is more important to know what sort of person has a disease. I think we have to remember that he said more. He didn't say it is important and not the other one is not important. You need to know the disease, but you need to know which patient you're treating. Next slide, please. And in 79, I completed my fellowship in oncology and joined this place in St. John, New Brunswick. And that was a beginning. And it's also an interesting thing because I'm a solitary person there. I went and started a medical oncology department there. And I'm the only medical oncologist east of Quebec City at that time in that country. So that's how I represented Eastern Canada in Royal College Committee to create a certification for medical oncology subsequently. And here also I learned how to talk to people and convince them that medical oncology is something that can be done. We're talking about 79, and there are a lot of physicians skeptical about these things. And secondly, I also got to know a lot of people across the country with the NCI. And as a solitary, I always used to pick up the phone and talk to them. And I still do that. And you all know it's very easy. And I think that's one thing we all should get over our egos and help each other. And also, it makes it more easier to life. And the second and next slide, after 3 years, they started building this hospital. This is a 110 million hospital in those days because that was smaller and that was built in 1931. And then at that time, they also partly computerized this hospital as a whole. So from the medical side, I was representing on the committee. So I learned something about computers as well in hospitalization and data as well, and the medical records. Next slide. And then in 85, I came back to Chennai, and this is the place I landed in, Apollo Hospitals at Chennai. And this was, again, there was no medical oncology department as we know here. And then I'm a lonely person here, and we were very few in the city as well. So again, I could easily talk to people at TMH and other places and just call them and say, I have this case, what do we do? Because those are all days that we don't have these nets and access to a lot of things. And second thing I learned here is that in Canada, we have a setup where it is like US one way and also UK another way. And that is the treatment is free, government pays everything, maintains infrastructure, but the patient can choose the doctor and the doctor can choose what he wants to do practice-wise, either a private or an employee of the hospital. So it was an interesting thing. But at the same time, the important thing is you need to know only one way of treating the patient and whatever the best that is. And you don't need to think of otherwise. When I landed here, the biggest difficulty was that you have to treat different ways a patient for non-medical reasons, apart from the patient and the disease. And that was a complex thing and very difficult thing, especially when you look at a curative treatment sometimes. When you think you cannot treat, it was very tough, but that is the country we have at the present. And at that time, much more, and even now to a large extent. So that is what I had to learn, how to deal with all this. That was a major thing we did here. And the next slide. And in 93, we built this hospital, Apollo Cancer Hospital, the first corporate cancer hospital in the country, complete comprehensive institute. And then one other thing happened at this point. Even earlier, about 1990, I started looking at these patients. There was a difference between Canada and here that I was practicing. It's not the same, the patients, and somewhere there is a difference in the disease as well as the treatment we're giving and the reaction to it. So with all these things, I felt I need to collect some data. So I got myself a computer and went to night classes, learned Lotus and DBase and WordPerfect and whatnot. But then I couldn't create any database. There was nothing that nobody could help me. Then 93, we started this and I kept going with it. And this was quite busy time. So it was few years went by. And in 99, one boy came and met me and said, we can do, somebody told him that Dr. Ramesh is interested in all this. So he came and he said, he can do that. I was skeptical. So I told him, okay, go and do it. After a week, he showed me a demo and he could do that. What is the VB with the front end and the back end of Access? So I said, fine. Then can we do something like this? Basically, what I was asking is querying the database. He showed me how to query the Access. And then I told him, we can develop something much bigger than this. It is not just simple what I was looking for. Next slide. And I also worked in this hospital. This is the railway headquarters hospital, Southern Railway at Perambur. Beautiful setup and beautiful hospital. And I loved working there. I went there to work for 3 years as an honorary, and I ended up working for 20 years. And then I had to leave because I felt I'm getting old. Then here also I learned that the patients and the disease behaves differently in ours. Next slide. Next slide. Yeah. And this is the Dr. Doval at his Calcutta Oration in 2014. He said the practice of medicine is in effect the conduct of clinical research. Every practicing physician conducts clinical trials daily. And I think that's what it is. Only thing, we don't collect data and we get the experience of individuals, our own experience as we go years. Next slide. And this slide is about NSLC, non-small cell lung cancer with extensive disease, as you can see, and GEMPLAT has come. And I have done studies where we had to use a placebo as a control arm at the time when the platinum has come. So from there on, I could see this. Next slide. And this showed a dramatic response. And again, of course, it relapsed. Next slide. And I have started collecting some data by that time. This was 2001. And I started learning and what to do and what not. And this is a Kaplan-Meier curve of about 40 patients of lung cancer I did on an Excel sheet. You can do a Kaplan-Meier curve in Excel and this is what we did. And you can see that there is a 12-month median survival for this. Most of these 40 patients are stage 4. Next slide. And so with this, as you can see with the Western literature, GEMS is 8.7 or 9 months. Generally, it used to be 9 months overall. And etoposide 7.2. In fact, here I must say, Govind Babu has done a study with cis and etoposide because it was given free in Ketwai for people who could not afford anything. And he has shown 7.2 months. And where the patient didn't get anything, they got only 3 months. So I think it's helpful, whatever we can give, and that is something to learn. Next slide. And of course, we didn't know what it was, but the ISLCL study came, and we could see the Asian subset did better, and of course, the EGFR mutation. And one day, Raju Titus Chaco and myself were sitting in a meeting about the pemetrexed, and he said, the EGFR mutation gives a good chemotherapy response also. And he said, basically, it's a good protoplasm. And the next slide, that's what we are having. That's how we got the 12 months for the median as well. So during this time, while we're developing this software, I started collecting data for the breast cancer with upfront surgery, which will be clean and no other things we have to think about. And around 2003, in fact, the software was complete and I distributed to many people. And of course, it was very complicated. We didn't know. And I was looking for something like for a drug research software, essentially, which can tell you on which day of a cycle, the most likely the toxicity is going to be, that kind of a software. Nobody could use it. And Dr. Pankaj Shah persisted with it and he's done a lot of demographics data in his clinic and had supported a lot of things for me. But this, when I looked at this one, 427 patients, as you can see at 20 months, we can still see few patients, but essentially around 2010, the active follow-up I stopped. Whoever came, I saw after that. So at 10 years, in fact, we have 78%, and follow-up is median is 112 months. Next slide. And next slide. And you can see the year-peer, sorry, go back one. And you can see the year-peer curve. Can we go back one? It actually, as people have said earlier, it crosses. And of course, it crossed maybe earlier because the HER2 was not done. Most of these patients, we don't know the HER2 status. So some of them obviously are positive. HER2 have done much worse and they have gone down much faster. Next slide. And I kept telling from then on that we need 10 times of the data and we can prove what I was showing with 400 patients. And this is the lymphoma registry we did 2004 to 2009. Roche supported. And as you can see, so many centers, including All India Institute, Tata Memorial Hospital, Nizams, and everybody was involved all over the country. And I must say, Raghunath Rao and Raghu, I call, and Reina Nair has really supported all these years what I have been doing and saying this is the way we to go. And Raghu has been an excellent support for this. Next slide. And you can see this is the data we collected and we published this data. It's not a great data, I must say, when we look back, but that's what we could do. But the fact is it did prove that we can all get together. This is on a access and VB front end on a desktop single computer software. And again, we did a special software for lymphoma alone, which was easy to use. So next slide. And this is the where we published in the ISMPO. Next slide. And what we did then is that we developed a full software again for all cancers, except the leukemias and subsequently even CML we did because Hemant and Hari, everybody kept asking for it. And we did that as well, so myeloma. So we have a software that can be used for all cancers, solid tumors, and hematologic except acute leukemias. Now, this software I presented at National Cancer Grid, and I must thank Dr. Badwe and Dr. Ramesh because they said software is good, and but they said cost and other things we have to think in our country. So I was thinking about it, and somebody close to me said, okay, this is what it is and it is needed. We will support and we'll create a foundation. You go ahead and plan that. That is how the Ramesh Nimmagadda Cancer Foundation is started. And also the software now belongs to the Ramesh Nimmagadda Cancer Foundation and owned by it. Next slide. And really the objectives to me is to establish a common platform because unless we collate data, we cannot get numbers enough and also the strength as well as ultimately we have so much data, so much work we are all doing in silos. And this will be something phenomenal as you can see. And initially it will be difficult, but then once we start doing it, it becomes usual. And the idea is also the individuals and institutes to form groups and pull data. And finally, to individuals and the institutions constantly refine as they analyze and look at that data. Unless we look at our data, we cannot tell what we need to do with our patients. Next slide. And really the vision ultimately is to create a repository of Indian data on treatment and outcomes to formulate India-specific treatment guidelines for cancer based on Indian data. Now, few people like myself, GS and Hemant and all of us with gray hair will sit around and say we'll tinker with the guidelines a little, with our experience a little, and put that. That's not the way we should be doing. Next slide. Next, yeah. The Collect works this way is each ABCD are institutions. And in the institutional server, the database and the program will be there and it is with them. And then you can pull the data together or you can keep yourself like in A, B, C, D, different studies they were involved with, and you can export the data, the pooling. Now, people don't have to worry about the anonymity of the data with this anonymizing the data, because even in your own institution, the data will not come out into the Excel for you to analyze with any of the privacy fields, both for patient as well as for the doctor. So I think that is very important and you don't have to worry. And it is an anonymized data, and the principal investigator of each study can download the data and analyze. Next slide. Now, then people started asking, why do we need two EMR and data collection software? And this is a major thing one has to think. And this was a talk I gave for the IT crowd of the healthcare in one of the meetings in 4 or 5 years ago. And EMR is actually electronic medical record. They keep talking about hospital management system, this and that, whatever it is for management of hospital. But as physicians, we should know our part in that is it is an electronic medical record. Basically, it used to be called EMR. Now the name changes. But the EMR, once we say it's a medical record, it is used for managing the patients and secondly, as a legal document. So it has to be properly done by us or our colleagues, but not by non-medical people. So that I think we have to keep in mind. And secondly, it is not digitized. And for research, you need a digitized program. So if you want to go back and do it again, you have to do it in Excel, all the work. So that is why data collection software should be separate so that all the patients' data can be done by somebody else, whereas you put what is important for you in digital format in EMR, but the rest of it is like any regular medical record. Only thing instead of writing, you put it in an electronic format. So there are two different things. Next slide. And they should be kept separate. There's no question. In India, for sure, I have no hesitation because you know what's all going on in the West, especially in US. There is a lot of burnout just from EMR itself. Next slide. And with our medical oncologist strength and oncologists for patient proportion, this is in 2015, and it still holds good because the cases also unfortunately are increasing as we are increasing in number. So I think it is not going to be something is going to happen to us. And even today in US, if you want to do a study in any of those institutions, they have to get the data back into Excel or some kind of another software, not from directly EMR, they cannot analyze. Next slide. So this is a New York journalist who writes for New Yorker and other things. He said, be skeptical, ask questions, everything. But when you get a proof, you need to accept the proof. And that is EMR is not the place for data collection. And we are not that good at accepting the facts. Next slide. And then somebody will be pushing for it. And now we have put the Collect in all these institutions across the country. And of course, there are 19 institutions, but all of them are not using. You all also know quite a bit. And maybe around 10 to 12 are using, and about 7 to 8 are using very actively. Next slide. And hopefully the others will join. And so far, there are these 7 hospitals. That is Rajiv Gandhi Cancer Hospital in Delhi, Dr. Doval, and Indo-American Hospital at Hyderabad, Senthil Rajappa, and Mahatma Gandhi, Mahavir Cancer Sansthan in Patna, Manisha Singh, and the Saroj Gupta Cancer Hospital, Dr. Arnab Gupta. All these people are the 4 that really agreed to pull their data completely initially, giving a lot of support to me and they have been really forward-looking. And at that time, the other three centers, that is the Dr. Ramanan at Chennai, and Mahatma Gandhi Cancer Hospital at Visakhapatnam, and Dr. Ravi Kannan at Kachar Cancer Center. These people joined in the last 1.5 years. Now, so far we have a registration details of about 1,050,000 patients, and primaries identified in about 382,000 in these patients, and surgical procedures documented in about 32,000, and histology is identified in about 211,000. And this, about 80, more than 80%, in fact, are imported from structured data, whatever they had coding, either in the medical records or in the some other section. And all that we took directly into the OncoCollect, and all registration details are imported completely directly. Next slide. So this can be done in 8 places, and this is the way the increase in numbers have happened. But then that is because at various times the individual institutions have been the computerized in registration. That is why the numbers increased at the stepwise. Next slide. Next slide. Next slide. And these are the things, as you can see, the breast cancer is the main, the blue are the females, and the red is the men. And as you can see, the blue, first blue is the breast, and the next blue is the cervix, and the next taller blue in the middle is the ovary. And the first blue, red is the head and neck. I lumped all the head and neck together because one of the things is for management, we need to know which part of the head and neck. But if it is going to be for looking at the demography and tobacco related and etc., we should lump the head and neck. And that's why I lumped it, and that is the tallest one, and the red, and the next one is the lung cancer. Next slide. And when you look at the time trends, so late Dr. Saroj Gupta has started coding these cytoprimaries from 96, and here we have from 96 to 2017, about 40,000 patients, and their patient population has been very steady over the decades, in fact, in that institution. And you can see cervix cancer from 41%, and it has, in the top 10, it has come down to 17%. And there was no screening done. It was purely hygiene and education and a little bit of economy. We all know that. And the breast cancer has gone up. And the head and neck cancer in the women also is the top at the yellow, third one. And the fourth one is the gallbladder in that area. Next slide. And then so far what we have done with it, the data we had, and this is Dr. Rita Rani presented at the ARI last year, and about the cervix cancer. Next slide. From these 4 institutions at that time, and now the Visakhapatnam Mahatma Gandhi Hospital also has joined. From 2017 and 18 together, we will expect nearly 3,000 patients data to be completed by the end of this year, and hopefully beginning of next year, we will write up the paper. Next slide. And this is the lymphoma group, Dr. Reena Nair from Tata Medical Center. All the red dots are the ones that are already contributed the data, and the blue dots are the one that has finished the ethical committee approval, and the Mohomi Baba Cancer Center is awaiting the ethical committee clearance. Next slide. And in 2019, Dr. Hari Menon presented at AIIMS, and it is at that time 2,500 patients were there, 11 to 16. Next slide. And at present, we have about 4,400 patients from 11 to 17 and completing data. And hopefully by the end of the year, we'll have 2,000 plus. A large B cell, we can write it up. Next slide. And this is the breast study we 3 of us did, Dr. Dinesh Doval, Dinesh Selvi, and myself. Next slide. And we have been collecting data on myself on the software. Selvi was collecting on Excel, and Dinesh was collecting in his book as well as in some Excel. And as you can see, from 2008 to 16, we wrote the paper on up to 14. 2008 to 16, we had more than 4,000 patients, upfront surgery, and it is about 88% median survival, DFS, and the median follow-up is 70 months. As I said, 400 patients, I need 10 times, and I think we did get 10 times so far, hopefully, and this is about 70 median. Next slide, 6 years. This is the receptor status in that, as you can see, again, they are going closer as we get to the 10-year mark. And of course, now these receptors were with the HER2 also, so we could clearly separate them out. Next slide. This is the first paper written by Dr. Swarupa Mitra from Rajiv Gandhi, rectal carcinoma in the young. Next slide. And next two papers were written by Dr. Selli Radhakrishnan, and the one in Indian Journal of Cancer, next slide, and on breast cancer, and also the one in Indian Journal of Medical and Pediatric Oncology. Next slide. And this is the paper, the poster at the Astro last year. Dr. Swarupa Mitra was presented for on gastric cancer. Next slide. And this is the paper we have written on the breast cancer upfront surgery. And I must say, really, this is the product of our data collection, but primarily the paper that came out is Sudeep's effort. And in fact, he saw the data when we discussed, and he said, this should be done differently. What we were thinking is not what he said, and I think he's right. And obviously, it came out very well. But I must also acknowledge that Sudeep has been helping in terms of initial development of this OncoCollect, because he has been a constructive critic. And ultimately, finally, in Coimbatore, one of the conferences, he said, yes, this is doable. We will do this. You can do this. So thanks, Kriti, Sudeep. Next slide. And this is the PINNER trial, and 80 and 100 milligrams of docetaxel was there in the PINNER. From then on in Finland, they used 80 milligrams. We'll come back to this. Next slide. And I think this is the Dr. Donald Pinkel and David Kornowski lecture in 78. And he said there is a shilabeth amongst some oncologists that the efficacy of treatment is directly related to its morbidity. The demonstration that our children with leukemia will experience the least morbidity are enjoying the best frequency and duration of remission clearly challenges this belief. Next slide. This, of course, unfortunately, as oncologists, we have a problem. And that is, we know what is on this slide. That is the efficacy relates to the drug on the cancer cell effect, and the toxicity relates to the reaction of the body to the drug. But, and both are independent. We all know that. But we are stuck with a problem. Next slide. And the problem is we only get the maximum tolerated dose. We don't know what the maximum efficacy dose is. So when a drug is started off, it is started at maximum tolerated dose. And then if it is working, they will try a higher dose. And that, if it is toxic or not working, they will stay with the original dose, which is still toxic. And but nobody will try a lower dose because nobody is interested anymore. And that is the problem. Next slide. And now, I have been saying that in our country, we need, because a lot of people need a different type of drug dosing. And we need to collect data. Now look at what happened in the West. And this is the HERA trial. This is an excellent example as far as I'm concerned, trastuzumab. HERA trial, and there was 2 years, 1 year, and it was same. So the next slide. And as we can see, when the cost was so high, and this is a French trial. Next slide. And this is the Ferret trial, and the French trial supported by the public funding. And this is important because no drug company is going to support when you want to reduce the dose and try. So this is what happened, as we can see. And it is our job really in this country to do for what we need for a lot of patients. Next slide. And it doesn't matter, you all know what the outcomes have been. Just I want to quickly show what happened. This is short hair study. And again, this is Italian study. Next slide. And again, done by the public funding. And as you can see, they put the Bayesian thing in the green, that the curve, and that says that 80% chance that is in fact, it is not inferior. Next slide. And this is of course, there was total planned dose of docetaxel was low. Next slide. And then when you look at this one, SOL trial, next slide, the SOL trial, and which is the again finished trial. So they did 80 milligram and 100 milligrams of docetaxel. Next slide. And that showed with 80 milligrams, you need 1 year. With 100 milligrams, 9 weeks seems to be sufficient. And that we're nice to see, but it's not small numbers. With 80 milligrams, it is 850 in each arm. And for the dose 100 milligrams, it is 250 per each arm. So I think we have to really look at. Next slide. Actually in the write-up, they did say there is an interaction between the docetaxel and the whatever the disease-wise, the treatment-wise. And so they concluded that cardiac safety was better than in the 9-week group, but the docetaxel dosing with transdermal requires further study. And of course, this was felt to be not inferior. Next slide. And this is Persephone, we all know, and that is again another publicly funded trial from UK, and there is a lot of discussion. Next slide. This was a positive trial. And then this comes recently. This is the Journal of Clinical Cancer Information, and here the immune checkpoint inhibitors and the real world data in the VA has shown it is not, it is lower than what was in the trials, but higher than non-immune checkpoint. So we have to look at it. Next slide. As you can see in the West, they all were doing now because they need it. But we have been needing it for a long time. We should be doing it. And this is Renan Iyer sent me this, and this is the TMH collected data over time. And you can see the various modalities was used at different time points, and the curve has come back up APML. Next slide. And this is the one I got from Dr. Govind Babu. This is in the ASCO post, and he says large sample size of data and the range of the hospital types make the information contained in Ford manual is a viable alternative to institutional or clinical trial data as a source of information for answering some research questions. Next slide. And this is a slide I borrowed from Senthil. And RCT, that is a paradox, he says, and the homogeneous to heterogeneous. We know that. Everybody talks about it now. But in fact, we were not looking at it because everybody was interested in the randomized control trials. But randomized control trials are needed. There's no question. For a drug, that should be the only variant, nothing else. But in the real world, it is different. Best way to assess if an intervention works, but arguably the worst way to assess who will benefit from it. Next slide. And even Dr. Cunningham from UK says extrapolating results from clinical trials for the regular patients can be restricted. And hopefully we'll confirm the safety and the potential benefits of new therapeutics in the clinic. And he's saying hopefully studies done in the same place. Next slide. Capecitabine is the best example. EU versus US patients. And again, when it was Europeans could do 1250 milligrams, US could not, and they found there is a folic acid may be high in the diet. So the diet can change. So in our country with various habits and everything, we have to think. Next slide. Okay, next slide. This is in European journal. Just want to show how the West is coming out with next slide, real world data all the time. And this is Dr. Pinkel again. The lecture should end with questions, but some final philosophical remarks are needed. However, we must also recognize that most children with ALL throughout the world do not receive the benefits of modern therapy because it is too complex, too expensive, too hazardous, and not accessible. Next slide. The Dole has put it in his address again. Few studies of survival or outcome analysis. Next slide. And this, I believe, really presents a unique opportunity because we treat differently to study them, and then we can see what factors really went in various doses, various drugs, various interventions. Next slide. For the same problem. Okay, and this is the state of the nation. This is again, Senthil has given me the slide, and there is 9,600 all lines of therapy for immune checkpoint inhibitors. As you can see, for a second cycle, 15% dropped out, third cycle, 35%, by 12th cycle, 90%. We know the patients who have benefited from the drug needed at least at present, we think 1 year. And if patients who benefited dropped out at 4 months, that means they have wasted their money as well, and it's much more difficult. So we're counseling where to do. But also this is an opportunity because now we can see what happened to the patients who dropped out at 4, 5, 6 months, the cycles, or 7, 8, whatever, and who have responded in that, dropped out, what happened? Maybe we will find something. Next slide. This is the slide I borrowed from Purvish long time ago. And as you can see, the three kind of people we have. Next slide. And we have to cater for all these people. But whatever it is, still, even for the people who can afford everything, maybe the toxicity is not at the tail end because it may not help very much. Next slide. And this is the epidemiology transition we have seen, and there is a difference in the country all across. Next slide. We have to cater for all this. So ultimately, evidence-based medicine is research, yes, RCT and everything, but the experience-based medicine is what you are actually day-to-day managing. And then that, of course, includes the resource-based medicine you factor in when you're in experience, and you collect it, the real-world data, and you analyze it, and that forms the really evidence-based medicine for you, for your local condition, wherever you are. Next slide. So I think we need to do in this country, with all of us having so much data in our place, with work we are doing, that we collect that and put in a structured thing, get together, and we'll have something we can clearly make out. And some randomized trial to be done, we need to do. Really, the best time to plant a tree was 20 years ago, but the next best time is today. I want to acknowledge the IT department and medical record department personnel in all the institutions, our development team, Tiru, Premia, and Odaya, and Nirupam. Thank you.